Chapter number 2: The historical view of scoliosis as only a spinal condition. Throughout most of recorded medical history, scoliosis has been viewed almost exclusively as a disorder of the spine. For centuries, physicians and healers regarded scoliosis as a purely structural problem, believing that the abnormal curvature of the spine was itself the disease rather than a symptom or manifestation of deeper physiological imbalances. This limited perspective, while understandable, given the observational tools of the time, shaped scoliosis treatment approaches for millennia and delayed broader understanding of the condition's true complexity. Ancient observations. The earliest known discussions of scoliosis date back over 3,500 years to ancient civilizations such as Egypt and Greece. Archaeological evidence shows that scoliosis was present in ancient populations, with skeletal remains from Egyptian mummies displaying clear signs of spinal deformity. However, there is little evidence that early Egyptian medicine offered treatments beyond rudimentary splinting or attempts at manual correction. The Greek physician Hippocrates, circa 460 to 370 BCE, often called the father of medicine, was among the first to systematically describe scoliosis. His writings in On Joints and other texts referred to spinal deviations and categorized them based on the direction of the curve. Hippocrates believed scoliosis resulted from imbalance or injury and suggested treatments such as axial traction, using pulleys or stretching devices, and postural correction. His famous invention, the Hippocratic ladder and board, involved strapping patients to a device that could apply force to the spine to correct its deviation. Even at this early stage, scoliosis was seen primarily as a mechanical problem, a visible, tangible distortion of the body's structure. Internal factors like muscle weakness, genetics, or biochemical imbalances were not considered. Consequently, treatment was directed solely at realigning the spine rather than addressing any underlying causes. Roman and medieval perspectives. Roman medicine, influenced heavily by Greek tradition, continued to treat scoliosis as a mechanical failure of the spine. Galen, 129 to 216 CE, a prominent physician whose theories dominated medical thinking for over 1,000 years, reinforced the view of scoliosis as a spinal anomaly. While Galen made important advances in understanding the musculoskeletal system, he too focused on external manipulation to correct deformities rather than exploring internal physiological contributors. During the Middle Ages, medical progress slowed significantly in Europe, and scoliosis treatment regressed alongside broader medical knowledge. The practice of spinal correction largely relied on crude devices, bracing, and basic traction techniques. The cultural and religious climate of the time, which often interpreted physical deformities as signs of moral failing or divine punishment, further marginalized those with scoliosis. Again, scoliosis was seen through a strictly anatomical lens, a spine that was bent or twisted in error. Renaissance and early modern approaches. The Renaissance brought a revival of anatomical study and scientific inquiry. Artists like Leonardo da Vinci and anatomists like Andreas Vesalius provided detailed drawings of the human skeleton, including observations of spinal deformities. However, the mechanical model of scoliosis persisted. Deformity was still equated with disease, and treatment methods emphasized forceful correction. The first known scoliosis braces appeared during this period, fabricated from metal and leather. These braces aimed to straighten the spine through rigid external support. Ambroise Paré, 1510 to 1590, a French surgeon, designed one of the earliest scoliosis braces and believed scoliosis could be corrected by mechanical means if caught early. However, even Paré's innovations did not depart from the core belief that scoliosis was simply a spinal problem to be fixed with physical tools. Notably, surgical intervention was exceedingly rare and dangerous during this era, as anesthesia and antiseptic techniques were not yet developed. Thus, bracing and mechanical traction remained the mainstays of scoliosis management. The 19th century, refining the mechanical model. The Industrial Revolution and advances in medicine led to more sophisticated approaches to scoliosis. Yet the underlying philosophy remained largely unchanged. Scoliosis was viewed and treated almost exclusively as a structural condition of the vertebral column. Doctors began classifying scoliosis more precisely, differentiating between congenital, paralytic, and idiopathic forms based on clinical presentation. However, all types were still approached as mechanical faults. Methods such as plaster body casts, increasingly complex bracing systems like the Milwaukee brace, and corrective gymnastics proliferated. Perhaps the most significant development in the 19th century was the emergence of orthopedic surgery as a specialty. Surgeons began to experiment with invasive methods to fuse or straighten the spine, although early surgeries were fraught with risk and generally reserved for severe cases. Despite technical advances, scoliosis was still treated symptomatically. Few physicians questioned why a previously healthy spine might begin to curve during adolescence. The notion that scoliosis might involve neuromuscular, genetic, or systemic factors had not yet taken hold. The 20th century, the rise of surgical dominance. In the 20th century, scoliosis treatment entered a new era with the invention of spinal instrumentation. Dr. Paul Harrington, an orthopedic surgeon, developed the Harrington rod system in the 1950s, a major breakthrough that allowed for surgical straightening and stabilization of scoliotic spines. The success of spinal fusion and instrumentation reinforced the mechanical view of scoliosis. Now, surgeons could correct the curve visibly and permanently by implanting metal rods and fusing vertebrae. This method became the gold standard for treating moderate to severe scoliosis and remains widely used today, albeit with more advanced techniques and materials. Interestingly, Dr. Harrington himself acknowledged that scoliosis was more than just a spinal curve. He famously stated, "Metal does not cure the disease of scoliosis, which is a condition involving much more than the spinal column." Despite his insight, mainstream scoliosis management continued to emphasize correcting the spine, often overlooking systemic factors. Non-surgical approaches, such as bracing and physical therapy, continued to evolve, but they too primarily targeted the spine's structure rather than its broader biological environment. Limitations of the historical model. By focusing narrowly on the spine, historical scoliosis treatment often failed to account for the condition's complexity. Many patients who underwent bracing or surgery experienced persistent issues such as back pain, reduced mobility, or progression of curvature despite successful mechanical correction. Furthermore, the emotional and psychological impact of scoliosis was often ignored. Patients, especially adolescents, struggled with body image, social stigma, and mental health challenges related to their visible deformity and the rigors of treatment. Without an understanding of the genetic, hormonal, neuromuscular, and metabolic influences underlying scoliosis, treatments were reactive rather than proactive. Only in the late 20th and early 21st centuries did researchers begin to look beyond the curve, exploring scoliosis as a condition rooted in complex biological processes rather than mere spinal mechanics. For most of human history, scoliosis was viewed through a purely mechanical lens, a problem of the spine that needed to be forcibly corrected. This perspective shaped treatment methods that focused on straightening the body without fully understanding or addressing the condition's underlying causes. While this historical approach did achieve some successes, it also imposed significant limitations on patient outcomes and quality of life. Only recently has a broader, more integrative view begun to emerge, one that sees scoliosis not just as a spinal deformity, but as a manifestation of systemic imbalances involving the whole body. This new understanding holds the promise of more effective, personalized treatments that not only correct the curve, but also address the true roots of scoliosis, offering patients better outcomes and a higher quality of life.